Welcome to Copilot Podcasts. Here's something that will mess with your head. South Korea spends way less on healthcare per person than the US, but gets basically the same health outcomes. Yet in both countries, your bank account still determines whether you get the care you need. Today, we're diving into who actually gets treatment when healthcare resources are limited, what a massive Stanford study reveals about income-based healthcare inequality, and why even universal coverage doesn't solve the problem. By the end, you'll understand how money shapes medical access and what this means for healthcare policy worldwide. Let me bring in someone who's been following this research closely. Help us understand what this Stanford study actually found.
So this study published in JAMA Health Forum is pretty groundbreaking. Researchers from Stanford, Seoul National University, and Harvard looked at over 400,000 adults, 224,168 in the US and 179,452 in South Korea to compare how income affects healthcare access in two completely different systems.
Wait, so they're comparing the US system, which is basically pay to play, with South Korea's universal healthcare?
Exactly. And here's the kicker. Even with universal coverage, South Korea still shows income-based healthcare disparities. They're just less pronounced than in the US. The study found that higher income adults in both countries had lower healthcare spending, greater preventive care use, and better self-reported health.
That's wild. So universal healthcare helps but doesn't eliminate the problem?
Right. And the numbers are stark. In the US, self-reported good health ranged from 71.1% in the lowest income group to 94.9% in the highest. That's a massive gap.
Okay, but let's step back. What does this actually look like in practice? Like, how does income shape who gets treatment?
Well, the study shows it happens in multiple ways. Lower income adults in both countries had higher total healthcare spending, which sounds counterintuitive until you realize they're sicker and need more emergency care.
So they're spending more because they're getting care later when problems are worse?
Exactly. Inpatient and emergency department spending decreased as income rose in both countries. But here's where it gets interesting. US outpatient spending actually increased with income, unlike South Korea.
What does that tell us?
It suggests that in the US, wealthier people are getting more preventive and elective care, while poorer people are stuck in this cycle of emergency treatment. In South Korea, the universal system seems to level that playing field somewhat.
But you mentioned that even South Korea has unmet medical needs despite universal coverage. How is that possible?
That's one of the most important findings. Universal coverage doesn't automatically mean universal access. There are still barriers, geographic, cultural, administrative. Plus, the quality and speed of care can still vary by income level.
And the income dispersion itself is different between the countries, right?
Huge difference. The income gap between the top and bottom deciles is 42-fold in the US versus 16-fold in South Korea. That wealth inequality directly translates to healthcare disparities.
So it's not just about the healthcare system, it's about the underlying economic inequality?
Absolutely. The researchers, including Stanford's Karen Eggleston and Harvard's David Cutler, concluded that structural and systemic policy efforts are needed, particularly in the US.
Now, I want to dig into something that's happening right now in South Korea. They're actually making some pretty significant changes to their healthcare system.
Yeah, the Ministry of Health and Welfare announced their 2025 action plan in January. They're putting KRW 30 trillion, that's about $22 billion, into bolstering essential and regional healthcare services over 5 years.
That's a massive investment. What's driving this?
They're facing a crisis in essential and regional healthcare. The government expanded medical school admissions for 2025 and launched a pilot program for physician assistant nurses. They're also restructuring tertiary hospitals to focus on critical and emergency care.
And they're also cracking down on who gets coverage, right? I read something about changes to dependent verification.
Right. They tightened regulations in 2025, and it had immediate effects. The number of registered dependents in the Vietnamese community dropped from 20,499 to 18,881 individuals. They now require legal documents and proof of actual residence in Korea.
So even in a universal system, there are gatekeeping mechanisms that determine who gets access.
Exactly. And this brings us to a bigger ethical question that researchers are grappling with. How should scarce healthcare resources be distributed?
That's a heavy question. What does the research say about the ethics of healthcare priority setting?
Well, there's this fascinating review by Joseph Millam that looks at the ethics of health research priority setting. He points out that there are always more valuable potential health research projects than resources to support them.
So it's not just about who gets treatment, but also what conditions get researched and funded.
Exactly. And the pandemic really exposed these ethical dilemmas. Healthcare systems had to develop triage guidelines for things like ventilator shortages. Suddenly, we're forced to confront who gets priority when resources are truly scarce.
That's terrifying to think about. How do you even make those decisions?
Researchers like Erik Gustafsson and Lars Lindblom from Linköping University argue that public values should inform these decisions, but it's complicated. You can't just let public opinion decide everything, but in a democracy, you can't ignore it either.
So there's this tension between what's medically optimal and what's democratically legitimate.
Right. And age becomes a factor too. There's research on age-based priority that shows this ambiguity between whether old patients should have low priority or young patients should have high priority.
That's a distinction I hadn't thought about. Those sound similar, but they're actually different ethical frameworks.
Exactly. And when you look at the broader research on socioeconomic factors, it gets even more complex. Studies show that socioeconomic status changes throughout life can impact health outcomes.
How so?
Well, research by Caroline Barakat found that people with consistently high socioeconomic status have the best health outcomes, followed by those who experience upward social mobility. But the effects of downward mobility are less clear.
So your economic trajectory matters as much as your current status?
It seems that way. And this connects back to the Stanford study. They found that socioeconomic status, measured by income, education, and occupation, affects not just your ability to pay for healthcare, but your health literacy and ability to navigate complex systems.
Right, so it's not just about money, it's about knowledge and social capital too.
Exactly. Higher SES individuals have better advocacy skills and can navigate healthcare systems more effectively. Meanwhile, lower SES individuals face barriers that go beyond just financial, transportation costs, time off work, understanding complex medical information.
And these barriers compound over time?
Yes. Research shows that lower SES is associated with increased rates of chronic conditions like cardiovascular disease and obesity, plus mental health issues. It becomes this vicious cycle where poor health leads to economic problems, which lead to worse health outcomes.
So what can actually be done about this? The Stanford researchers mentioned structural and systemic policy efforts.
Well, South Korea's approach is interesting. They've raised the standard median income by record rates for 3 consecutive years, from 5.47% in 2023 to 6.42% in 2025. They also eased eligibility thresholds for basic livelihood support for the first time in 7 years.
So they're attacking the underlying economic inequality, not just the healthcare system?
Right. They expanded support programs too, raising stipends for young adults preparing for independence from 350,000 KRW in 2022 to 500,000 KRW in 2024, creating over 1 million job opportunities for seniors.
That's a comprehensive approach. But even with all these efforts, the fundamental question remains, in a world of limited resources, who gets treatment?
And that's what makes this research so important. It shows that even well-intentioned universal systems can perpetuate inequalities if we don't address the underlying socioeconomic factors.
The data is pretty clear that income remains a powerful determinant of healthcare access, regardless of the system structure.
Exactly. And the researchers found this across multiple domains: access to care, preventive care use, behavioral risk factors, self-reported health. Income inequality shows up everywhere.
It's almost like income is this master variable that affects everything else.
That's a good way to put it. And what's particularly striking is that the US and South Korea achieve similar overall health outcomes despite the US spending much more per capita. It suggests that how you distribute care matters as much as how much you spend.
So efficiency isn't just about cost control, it's about equity too.
Right. And the research suggests that narrowing income-based disparities requires coordinated multi-sectoral policy interventions. You can't just fix the healthcare system in isolations.
Okay, so when you step back from all this research and data, what's the big picture here? What does this tell us about who really gets treatment?
The big picture is that your zip code and your paycheck still matter more than they should, even in the most progressive healthcare systems. Universal coverage is necessary but not sufficient.
And the implications go beyond just healthcare policy, right? This is about how we structure society.
Absolutely. The research shows that addressing healthcare inequality requires addressing economic inequality, educational disparities, and social mobility. It's all connected.
So the question who gets treatment is really asking, what kind of society do we want to be?
Exactly. And the data gives us a roadmap for how to get there, but it requires political will and sustained effort across multiple sectors.
Well, here's what this research really shows us. The answer to who gets treatment isn't just about medical need or even healthcare policy. It's about the fundamental structure of our economies and societies. South Korea's spending less but achieving similar outcomes proves that how we distribute care matters as much as how much we spend. And that's a lesson every healthcare system needs to learn.
두 눈이 마주쳐요. 그대의 눈빛이 날 비춰. 우리는 서로